Hi, everyone. My name is Annette Newman, and I am thrilled for the opportunity to be able to share my passion for burns and disaster preparedness with you today. This training is for first receivers at the hospital level, but the basic concepts are applicable to all levels of burn response. And this is titled Management of Burns in a Disaster Setting. For disclosures, the Mountain Plains Regional Disaster Health Response System Just-in-Time Learning Series is funded by ASPR, but the content is a product of myself and doesn't represent official policy of the United States government. And this is absolutely not meant to be a substitute for professional medical advice, diagnosis, or treatment. I have no conflict of interest, and this is for training purposes only. And the objectives today are as follows. So for the next 15 to 20 minutes, we will review the significance of managing burn injuries in disasters. We'll discuss the initial evaluation for the patient with a burn injury, prioritize medical management in disaster settings, and discuss a few available resources. So treating patients during a disaster is a messy business because our focus changes from doing everything for everyone to doing the greatest good for the greatest number of patients, as we'll likely be working with limited resources. And this mind shift is often really difficult. The scarce resources are generally centered around staff, space, and systems. And the problem is the number of patients involved in an MCI or disaster can rapidly overwhelm the emergency response system. They can impair identification of patients with critical injuries, and they interfere with treatment and transport of priority patients, which means those in the hospital setting may not always get burn patients quickly, especially if this is a disaster with mixed trauma and burn. For those who are not already aware, burns are very labor intensive, so even small numbers can quickly overwhelm local resources. The other issue that interplays in disasters is that normal triage systems such as START and JumpStart aren't really designed for burn patients, as they focus on ambulation, respiration, perfusion, and mental status. And as many know, burn patients are usually awake, alert, and oriented initially, even with massive burn injury. So in an MCI, when the incident commander in the field yells, "Hey, if anyone can hear my voice, come on over," the burn patients will all be walking that way, and they may go to the green triage area initially. And as you may be aware, triage is a dynamic process, and it's adjusted according to supply and demand and the changing patient status. The other disaster consideration that interplays here is because burn patients are usually okay initially, they can leave the scene, jump in a car, and show up via private vehicle to the closest health care facility. And so that will impact you at that facility. So let's get down to the meat and potatoes of the session. So you are working your shift in the hospital and you get a radio call about a local mass casualty incident, and you have 15 minutes till you get 15 patients. So what do? So let's look at the essentials here. Well, first of all, we want to prepare that environment. We want to crank up the heat. We want to check the fluid and blanket supplies. We want to get K-thermiers or bear huggers ready. We want to have a huddle with the staff because staff readiness is really, really important. We want to check our resources. So if there's any burn resources that you have in your facility, we want to review that because oftentimes burns are a low frequency, high risk patient. So there's not that muscle memory there. And then really important is to prepare people for what they may visually see, because burn patients are anxiety causing because of the way they look. And that impacts the way us as caregivers provide care to those patients and can interfere with care delivery. So maybe additional staffing might be required, and assigning a place for the less acute so they don't bottleneck the emergency department can also be a really good way to kind of think through these patients as they will be incoming. The other thing that might be important here too is to reach out to the local burn center and give them a heads up, because it doesn't matter if you don't see the patients, if you just give the burn center a call and say, "Hey, heads up, there's something going on, we may need your help." But that forward leaning can be really helpful. So the burn center that maybe is closest to you that you work with can then take a look at the patients that they have and think who they can move in order to best assist you if you end up with a surge. The other thing that is really important, regardless of anything that we're about to talk about, is that trauma always takes precedence. So the important thing to remember is that burn patients are always tachycardic because of that fight-flight response. So unless they're on beta blockers, right? So they're usually normotensive or hypertensive due to the catecholamine release and vasoconstriction. And so they're usually awake, alert, and oriented. And we just mentioned that because that also impacts triage. So if you have the patient when you receive your surge whose vitals are any different to this, and a beta blocker use has been ruled out, then strongly consider trauma here. Usually the most frequent traumatic injury in an MCI or a disaster situation is due to an explosive mechanism. So it could be a gas line. But remember that that blast wave can cause significant trauma, especially to the lungs. So when you think about these incoming patients, think about the etiology, and that may be really important, especially when you're considering a traumatic mechanism. So even if you have never taken care of a burn patient before, as long as you adhere to the standard principles of trauma management, you'll be fine. That standardized approach should always be the same, that ABCDE sequence. So note there's no W in here for wounds. The primary survey focuses on what will kill a patient. So let's review that burn-specific information. So first of all, we go to our A's, so our airway, and this is specifically from that burn perspective. So if you see a patient come in through the emergency department and you talk to that patient and he talks back or she talks back, then you know the airway is patent and then protecting their airway. You should have a good indication of whether there could be inhalation injury present by the etiology of injury. So if these are a group of patients that have been stuck in an enclosed space for a long period of time, then inhalation injury is a potential. But if that is not what the scenario is, then inhalation injury is probably not going to be something you're concerned about. You also think through, is this a patient with a facial burn and do they have edema formation? That's not necessarily cause for intubation, but to think through all of these flags is really important. And the biggest in the A's is, does this patient have greater than a 20% total body surface area of injury? And why that is important is that this is the trigger for full body edema formation and potential occlusion of the airway. So if I have a small burn, if I'm just injured to my entire arm, which is 9%, I'm only usually going to swell in the area of my arm. I'm not going to swell anywhere else. So it shouldn't impact my airway, but that greater total body surface area does impact that fluid movement in that tracheal area. And we'll talk about that upcoming. We'll do a detour. For the B's, we're going to do what we always do, listen and observe breath sounds and inspect the chest wall. And the Advanced Burn Life Support course through the American Burn Association does recommend starting 100% oxygen via a non-rebreather, but for disaster purposes, we may have to prioritize whether that is done in regards to what is going on with the patient for that B section. For our C's, we want to, obviously, as we always do, check our pulses and our heart rate, check our blood pressure. Remember, hypotension is not normal. If your patient is hypotensive, there is a problem, and the problem is not the burn. Remember your advanced trauma life support. And this is a time when we look at our patient and think, are they over about 15 to 20%? Because if that's the case, then fluid initiation is recommended. So we think, does the patient have an entire torso that's burned or an entire leg? So this is a large body surface area. This is not just splotches to an arm or a leg. This is a large, a visually large area that is impacted. And in that case, in the primary survey, we're going to start lactated ringers or NS if you don't have LR at those rates that are indicated on the slide deck right there. So if you have a patient that's less than 5, we're going to start the fluid at 125 an hour. Those within the ages of 6 to 12, we're going to start it at 250. And those over the age of 13 are classed as adults, and we're going to start that rate at 500 mils per hour. And this is new. As of 2023, it used to be that the age was 14, but this has been lowered to age 13 in that new 2023 Advanced Burn Life Support rewrite. We're then going to look at our patient for our Ds and disability. Remember, our GCS is often 15 because these patients initially are awake, alert, and oriented. And then we're going to think about our Es, and this is really, really important, and we're going to do a detour on temperature also. So our Es, we're going to remove clothing, we're going to look for bruising, etc. We're going to remove jewelry, and we're going to try and maintain that temperature by keeping the patient warm and dry. So let's do our first detour. So if we think about our upper airway, then we've got to remember that the trachea is the size of your pinky. So a 3-year-old pinky is much smaller than my, I won't actually give my age, is much smaller than my pinky, right? So a 30-year-old trachea, for example. So if we have a patient with a large body surface area of injury, remember that can trigger edema formation even in areas without the burn. So in a disaster situation, this is really important because as we think about ventilator allocation, we want to be really cautious who we intubate and who we do not. So now let's be clear here. I'm definitely not saying to not intubate a patient with a large body surface area of injury, because once you lose the opportunity to intubate, you have to resort to a surgical airway. So early intervention is preferable. However, this should probably be done in consultation around that total body surface area with a burn center subject matter expert. And we'll talk a little bit also about that upcoming. The other thing to note is that singed nasal hair alone does not warrant intubation. The patient has to be showing symptoms. And if they're talking like a lounge singer, but they're not a lounge singer, then that's an indication that their airway is starting to get tight. And if they have swollen eyes and lips, so they can't open their eyes very well, or their lips are protruding, then think around that early intubation. And regardless of what is decided, securement of that endotracheal tube is imperative. We cannot lose that tube because once swelling begins, then that, and again, the swelling is progressive, but once that patient begins to get really swollen, if that tube is lost, then we've lost a patient. And then also to remember that frequent and adequate suctioning may be required in these patients that have usually been in a carbonaceous environment with that smoke. And as we think about smoke, right, so let's move to true pulmonary injury, which is below the glottis. Usually these patients have been in an enclosed space. And remember that the only reason you see smoke is because of the toxins it contains, and this damages the pulmonary bronchial tree. Now, what's important in a disaster situation and what's important in an everyday situation, to be honest with you, is that these symptoms may be absent for up to 72 hours. So initially, they may have a clear chest x-ray, and then 2 days later, their chest x-ray will be completely occluded. And then they present with hypoxemia and infection, and this facilitates multiple organ failure. So to make sure that these patients are some of the patients that maybe are transferred early, might be something to think through. But again, remember that this is not an indication, even if they have been in a smoke-filled environment and questionably do have a true pulmonary injury, this is not an indication for prophylactic intubation as you think around scarce resources and around ventilator assignment for those patients that would most require them. Let's also do a temperature detour before we go on. So what is really critical about burn patients is that the temperature affects the tissue. So we want to keep these patients warm. Remember, when you lose your skin, you lose the ability to maintain your temperature. So these patients get cold quickly. And there's 3 zones in a burn. So there's the zone of coagulation, which is that white part in the picture right there. That's not coming back. No matter what you do, it's dead. There's the zone of hyperemia, which is around the malleolus, and that area will usually do okay no matter what is going on with the patient. But then it's the zone of stasis, which is around that white part, that we want to ensure has optimal perfusion and optimal warmth. Because remember, your patient is vasoconstricted, so they get really clamped down, and so they lose that perfusion to that area. So we want to ensure that temperature is kept up. So the big thing that we tell folks to do, and that is imperative in a disaster situation, is to check the temperature. It's actually the #1 missed vital signs when I do chart audits. So to ensure that patient is kept warm and dry is really, really important. The other thing, as we continue with temperature detour, is the triad of death, which is really well documented. Hypothermia is a frequent pathophysiological consequence of burn injury. So they remember patients get cold quickly. And clinical studies have shown that there's an excess lactic acid production in the presence of hypothermia, and that hypothermic coagulopathy follows. And this significantly increases morbidity and mortality for these patients. So we want to keep these patients warm. So let's move into our secondary survey, and we're just going to focus on the burn specifics, right? Because this is a full head to toe and sample history, et cetera. So we're only going to follow our burn specifics, and that's depth of injury and total body surface area, which will drive everything moving forward. And then it's calculation of fluids if needed. So what is really important here is to remember that in burn centers, we don't usually resuscitate patients that have burns less than 10%. Very, very infrequently we may do so, but 10%, just to kind of give you an idea of what that area is an entire arm, and then I call it a high five. So it's a PAMA surface inclusive of the fingers, because the PAMA and fingers are 1% of your body. So we don't even normally do a formal resuscitation on patients that have wounds under 10%. This is also new per the American Burn Association. So this is your adults and children 13 years or older get 2 mils times the weight in kilos times the total body surface area of injury. And that is now divided by 16. Again, this is new as of 2023. Infants and children less than or equal to 12 get 3 mils times the weight in kilos times the TBSA divided by 16. Plus, they get D5LR at a maintenance IV fluid rate using the 4-2-1 rule. And I've got a slide that will talk through this a little bit later, and that is new. And that's because pediatrics need a dextrose source to maintain blood sugar. And so we've added that D5LR. It used to be up to 30 kilos, but now it's even above that. And then any electrical injury is 4 mils times the weight in kilos times the total body surface area of injury divided by 16. So let's look at images of depth of injury. So the most important picture really is the first image of superficial injury, as that is not counted and is usually the reason for burn surface area overestimation. So the other is anything that doesn't have epidermis, right? That is counted in the depth of injury. And the other consideration is in that area of 3rd degree. So what's really important is that area in a 3rd degree injury gets really tight. So if it's circumferentially around a torso or around an extremity, and that can develop compartment syndrome as that fluid shifts. So to monitor that is extremely important. It's really rare that an escharotomy has to be cut early, but we've absolutely talked to flight teams through how to do it prior to transfer, specifically on the torso, as that can impede ventilation. But that lower picture in that 3rd degree area is a picture of an escharotomy, which is due to a circumferential 3rd degree injury, which needs to be opened up in order to ensure perfusion continues to that extremity. Not something that is required early on and should be done in consultation with a burn center. So fluids given depend on an accurate total body surface area of injury, and this is most often used by burn providers. The rule of 9s is most often used by burn providers, and the rule of PAMS. Usually burn centers use the London Browder chart, which compensates for variations of body shape with age. But this is really difficult to do prior to debridement, and in a disaster situation, wound care is probably the last thing that you will be doing early on. And then remember also, formal resuscitation here is not usually given to those less than 10% total body surface area of injury. And using a burn center to assist with this, using telemedicine or the transfer of images can be really helpful. And this is why. So burn size estimation is really a crucial component of acute burn management, and it guides referral to burn centers, it guides fluid resuscitation parameters, it guides hospital resource distribution and mortality-based interventions. So referring providers often misestimate the total body surface area of injury, which contributes to unnecessary healthcare cost and misappropriation of limited resources and delay in provision of appropriate patient care. And in a systematic literature review found TBSA calculations ranging from 5 to 339%, regardless of provider level. So underestimation is more likely with large burns. Overestimation is more likely with small burns, which is something we see in most every patient that is referred to us. So really, it's just best to be Goldilocks, right? To get it right, especially in a disaster situation where conservation of fluid and conservation of ventilators is extremely important. So let's walk through this together before we move on. So let's calculate fluid for a 26% total body surface area in a 10-kilo pediatric patient. So we've got 3 mils times 26% total body surface area of injury times 10, so 3 mils times 26% times 10 kilos equals 780 mils divided by 16, and that equals 48.75 mils per hour of lactated ringers, or NS if you don't have LR, but hopefully LR is something that you have on hand. So let's just say 49, right? And then in this patient, because they're pediatric, we also want D5 LR with the 421 rule, which would equal 40 mils an hour. So this patient will get total fluids of 89 mils per hour, and the lactated ringers will be adjusted according to urine output, and we'll talk about that in a minute. And the D5LR will stay at the rate of 40. And remember, you can always call your local burn center for assistance here. So formulas only estimate fluid required, and burns vary in response. So the single best monitor of resuscitation is urine output. We want to discard the first amount of urine. And remember, this is only for those burns that require resuscitation. So then a Foley will be inserted. We'll discard that first amount of urine, and then hourly observations of urine will be done for every hour after that. And this, again, is going to be very labor intensive in a disaster situation. We want 30 mils for our adults, a mil per kg for our pediatrics. And then if there's an electrical injury, as indicated by the myoglobinuria in that picture right there, so it's kind of a reddy color, then we want to ensure that we have 75 to 100 mils of urine for adults, and then 2 mils per kg in pediatric patients. So this would be when resources are really scarce. So if you're thinking about a really massive disaster, then think through maybe only one IV or IO line should be inserted until it's determined that adequate resources are available. Priority should be given to patients with large burns and then with associated trauma and blood loss. And there is really great evidence around oral rehydration, which can be used if the IV access is unavailable. And this can be done in patients up to 20%, and then even some patients up to 40%. And there's some oral resuscitation examples in the bottom of that slide right there. So this slide reviews the ABA referral and consultation recommendations. And obviously in a burn center, in a disaster, burn centers can also be overwhelmed. And care of appropriate patients by non-burn centers may need to occur. And most states have been working on a burn surge annex by their coalitions that should have plans for this. And so hospital systems should be able to take care of patients for prolonged periods of time based on those annexes. But consultation, again, with a burn center and review of American Burn Association recommendations is a really good thing to do prior to a disaster occurring. So let's just mention a few words on pain management. And the big thing here is that burns hurt. So they have those exposed nerve endings, and so covering those nerve endings assists with that pain load. What's really important is to educate the patient about why they hurt and to tell them what you can and can't do, because the patient will likely not be pain-free even with medication. So for providers to tell the patient that you can give them something that will assist, but it may not take away all of the pain is really important. And then consider covering those wounds with dry dressings if the patient will be transferred to a burn facility. Will also be something that decreases that pain load. The other thing is to not use excessive pressure when you're touching the wounds, so to use flat hands, to not grab them with fingers, and then elevation of burned extremities also, again, decreases that pain load. We recommend small amounts of narcotics frequently with reassessment, so that that patient that's breathing then doesn't stop breathing because they've been given too much pain medications because they're complaining that they need more. So to ensure that frequent reassessment occurs, and then nothing should be given to these patients IM, because again, remember there's that edema formation, and then there's that third spacing of fluid that can occur. So we're not quite sure when IM medications will be released. And the important thing here is to remember adherence to your local protocols, whatever they may look like, and to give the medications you are most familiar with. So let's also, before we move to psychological support, talk a little bit about wound care. Initial debridement includes washing and removing of that dead skin. Now, this may not be something that occurs early on in the disaster as we try to take care of those patients in the surge that most need care. Wound care can be done wherever the patient ends up. And certainly, as a person that works in a burn center, patients are sent all the time without wound care being done. So that initial care can be delayed if the patient will stay in that facility that received the patient. Then to know that anything that blanches, anything that's partial thickness, as we think about that earlier slide that talked about depth of injury, then bacitracing, if the patient is not allergic to that, can be certainly placed on with nonstick dressing and then covered with gauze and secured with netting or tape. And then deep partial thickness, and those that are third degree can have silver dressings applied. We actually use a lot of silver sulfadiazine, although a lot of burn centers do not necessarily use that because, again, it's labor intensive. So they use more silver dressings, but we still use it, and it works really great for our patients. But the most important thing here is to remember that there's no special burn dressings, to use what is readily available within your healthcare facilities. And the most important thing is that this is not rocket science, and to keep the patient warm. So to make sure they're wrapped in blankets, to make sure that when dressings are done, that is not prolonged and the patient doesn't get cold. So checking of the temperature is really important here. Psychological support is also just so important. And we learned some lessons around the Hawaii wildfire response here. So disasters and burn injury have a significant psychological impact on both the survivor, the family, and the responder. And that includes those at the hospital and the first responders in the field. And so that psychosocial support and crisis counseling and resources that are given to those affected are essential, because we want our patients to survive and thrive, right? We don't just want them to survive. We want them to thrive in their recovery. And what's really key to remember is after that surge has ended, to have a debrief with the crew that's on specifically around this, and to do after action reports, to loop back with burn centers to ask about the care delivered. But debriefing is really, really important. And here's a picture of one of our burn camps Most burn centers have lots of resources. So they have peer support, they have camp programs, they have aftercare programming. And so to ensure that even if patients are not sent to burn centers, that this support is sought after. Burn centers are usually happy to support even those patients that have not come through their centers. Just in a fast review, the West has a variety of comprehensive resources which can easily be shared and accessed. Here's a few that speak specifically to regional plans within the West, acute care and inclusion of burns in tabletop exercises. But these resources prevent really us having a 2 p.m. meeting to solve 2 a.m. problems, right? The Mountain Plains RDHRS has some amazing resources, as do multiple other grant groups, such as the Pediatric Pandemic Network and Western Region Alliance for Pediatric Emergency Medicine Management, and other pediatric disaster centers of excellence. And don't forget your local burn centers, who may also have some resources that can be utilized. And that collaboration and that partnership with your local, at least your closest, but hopefully your closest to burn centers, is something that really should be thought about pre-disaster. Here's a page of references for your review with some of the information that I've given. And then I really want to end with a call to action by Goethe. And that's knowing is not enough. We must apply. Willing is not enough. We must do. And I added some pictures of a few of the reasons that I'm motivated to do the best I can to prepare for a really bad day. And I challenge you to think of what motivates you and to reach out to your local, state, and regional partners to collaborate. Thank you for listening.